Today, we're in the middle of something different, uh, but again, exploring and pushing. What does it mean to be resilient in the face of different types of disasters? What makes this one different is, I think, at the first level, the scale at which it operates. We have not had something where we're now dealing with it at a worldwide level in terms of the spread of a new infectious disease. We haven't had it happen at a continental level, where you have things spreading currently across Europe and the United States, as examples. We haven't had it where it challenges entire national healthcare system. So we have this mix of multiple levels where a surge of patients can challenge a individual hospital, individual mix of emergency department, ICU, other hospital resources, but it could also be challenging a whole city's resources.
Why is resilience the right way to be thinking of a worldwide pandemic rather than the kinds of risk metrics that we've seen that compare fatalities from coronavirus to fatalities from normal seasonal flu, or make other kinds of risk comparisons?
Looking at it in the context of this event, I think highlights why a risk focus is really not actionable. It doesn't confront the real things that matter, nor does it confront the way that individuals need to think about their behavior and how their behavior should coalesce and synchronize and synergize with others, because we have to get this synergy across scales. Right? You can't just solve it at a big scale. You can't just solve it at a local scale. Or these all have to be reinforcing scales. That's one of the issues in this that says most of the modeling of infrastructures and these things has completely missed the boat. The emphasis on risk, I think, has missed the boat. It's not about risk, it's about control. How do you control the transmission vectors? And so what do you see people do? It's, in some ways, basic public health, basic epidemiology in an outbreak situation. You got to identify people who are ill. You got to trace contacts. You've got to restrict those people to break the transmission, reduce the transmission. So yeah, risk matters. It's the differential risk between certain populations and the ones most at risk. When you have fatality rates that vary, we've got this differential risk of serious illness that requires aggressive hospital treatment. That's the number you care about. Who has to go to the hospital for aggressive treatment? Now, the number that I have yet to see, right, which is the number I really, really want, is who recovers from aggressive treatment. What's the difference between people who just recover, right, get ill and get better, versus people who need aggressive treatment to get better?
So I've seen this in a couple of discussions. The idea that we have to intercede to break the transmission chain would be that instead of a big peak like this, we would flatten out the rate of infection curve over time. The problem with the big peak like this is, if this is the number of people who require aggressive treatment, and this is the number of ventilators or respirators available, then we are going to leave these people without treatment and the fatality rates go way up. Whereas if we slow down the transmission, we can get the treatment to the people who really need it. Is that your understanding?
By the time everybody knew this and started to say this, they were already weeks late.
Yeah.
Right? By the time this became circulating, and of course, because people like us have noticed that this has finally come out, this should have been, and I don't know for sure how widespread within the medical response communities and the authorities, the medical authorities trying to plan interventions, how quickly they understood it. But from the fact that because of the scale we operate and the multiple scales that have to be synchronized to deal with this, everybody needs to understand this. And clearly that is only beginning to happen. I was trying to call up people and tell them to talk about this early last week. right? And I would say this week this has become widespread in some media outlets if people are really interested and really careful and really thinking about it. So we'll get into at some point the anticipatory anticipation paradox in these situations, and we'll have to talk about that. Now, the next thing in this is your shaded area. So that area, what that is anyone within the healthcare system, within the higher echelons of the healthcare system, and then the public prepared for triage decisions. Now, triage is a medical word that everyday people hear, and sounds like a nice word. We go to, we have a mass casualty event and there's triage. We hear about this in military campaigns where there's multiple injured parties or wounded, and we hear of triage and we think of this as part of medical care. What triage is a sacrifice decision, right? It's a way to say, who could benefit? I have limited resources, and I need to allocate those limited resources to have the maximum effect, considering all of the injured, not maximizing care, maximizing probabilities and recovery for each individual.
So because of the sheer number of people who need care, not everyone is going to get it. We think of allocating it as a medical decision, but it will inevitably have political and social consequences in the United States.
Right now, we have an allocation problem. We have a saturation allocation problem on access to testing.
Yeah.
With the places that have gone and said this is because they already have free at point of care, or because it's easy to make it in a special situation free at point of care, whereas we're seeing places that are less prepared and less aggressive are in effect making a kind of triage decision.
Yep.
Now, nobody, part of the issue in triage decisions is how do you get people to accept that the standard of care isn't going to quite be met? Now, what does that mean? Is that like a surge in an ER on a bad night in a busy ER where some patients are in the hallways on beds? Is that long waiting times, whatever? In this case, it becomes much more critical because of the critical health risk, right, is pneumonia, right? So you have a severe form of pneumonia, you have respiratory failure risk, that interacts with other comorbidities, and so you have a high risk. That specialized care, how do you expand the pool of specialized care? And you've seen this week in accompanying the drawing you made a lot of a commentary that places needed to act early to build capacity to handle and treat respiratory illness. They had to expand their capability, and they needed to do that ahead. So what this plays into is back to control. And as this scales up, and I put this out over 10 years ago, I thought it was a temporary, provisional kind of layout, and I've been shocked that it's held up as well as it has. And it's a very simple 3-word sequence: deploy, mobilize, generate. And right, that the surge, the risk of saturation of the critical healthcare capabilities means, what's my deployable capability? Given the way most systems operate, we operate with a very thin margin because it would be otherwise inefficient, not optimal for hospital finances, for their capital investment in operating rooms and ICUs, et cetera. So we need to have more optimal utilization. What plays out then is you're going to exhaust your deployable capability really fast. So in one study we did not long ago on a 500-person mass casualty event from burns, we found that one of the EDs that received patients normally operated above its surge capacity. Whoa, what?
Normally.
It operates above its surge capacity?
It's an oxymoron. Yeah.
Right? Isn't that odd? Right? So it's already adapted and adjusted its nominal capacity to handle more patients than its official design is already built into its set of adaptations and real practices, how it really operates in the world.
The scale of that event hypothetically allows redistributing the patients to other hospitals where there are other resources available, because that is a geographically specific event. What we have here is more widespread. For example, to build new capacity in ventilators and respirators requires us to activate a global supply chain, which might depend upon critical components that are in areas that are already quarantined. And therefore, we cannot build the capacity we need just because we can't get the parts.
So you jumped to generate. I was
Yeah,
going through the
okay, right.
sequence.
Yep.
So deploy, mobilize, generate. And so we have some deployable capability, in part because we get surges in many of these critical areas in these systems and how they operate. One of the reasons we've studied large mass casualty events, 500 burns simultaneously overloaded multiple hospitals in the area near the where the tragedy happened.
Yep.
And so we were able to study how multiple institutions, and you can't now, grab capability in the same way that you would like from nearby, but not as affected places. So now we're starting to say, how do I mobilize additional capability? You've heard this from Italy, where everyone's a pulmonologist now. Every physician's a pulmonologist now. It doesn't matter what your specialty is, right? So we're mobile. They're there. They just have other specialties, and now we're integrating them. And so we saw this in our study of the mass casualty event, where there was a shortage of burn specialists. And so now the burn specialists, or the burn knowledgeable people, are now orchestrating other clinicians who are skilled clinicians, but not specialists in burn treatment. And how do they use and adapt the protocols on burn treatment to fit the patient load, and how that saturates and overwhelms a variety of kinds of resources. One is expertise.
Yep.
And that's new and different than on the standard lists of factors that go into things that might get short. Now, they have to reorganize. They have to change some of the protocols they would normally follow, because they're working with a cohort of patients. They're trying to maximize the care for the whole cohort, not just for each individual patient. And so those two are going to be different. And that difference, whether we use the triage word or not, is necessary. But we're in the moment dealing with saturated resources, right? Shortages of expertise, whatever. So so this adaptation, these processes of adaptation, what do I deploy? You've seen this in people have essentially been triaging testing in the United States, because we've been slow to build testing capability in a way that shocked the world. So then we get to generate. And here we are looking at something that's operating on a scale of thousands of deaths among the most vulnerable populations as the virus spreads through communities and cities and regions. So the scaling up means we now have to generate. And this is the thing we've seen in really almost from the beginning of building a community, of exploring what it means to build and engineer resilience into many kinds of processes, which is the plans that we build for the contingency plans we build fall apart very quickly, because we miss many of the hidden interdependencies that get activated in these situations. And so we now rely on to generate or to mobilize, but certainly to generate capabilities. We find out that there are hidden interdependencies that block the ability to deliver what we thought we could. And so this is where contingency plans, just in large extreme weather events like hurricanes, all assume that there is the same backup resource available. And that is either also degraded or knocked out by the extreme weather event, or it quickly becomes oversubscribed because multiple parties, all contingency plan, all relied on that same resource in the background. And so it quickly becomes depleted or fails from being overloaded itself. And so you see breakdowns occur. Now, in principle, our colleagues have been trying to go out and model infrastructure lifelines to look for these interdependencies. And I think we have here today both an example of the regularities of surprise, that it's a surprise, at this scale in many ways, though we could point to things about what are the critical capabilities and how do they get oversubscribed and saturated? How do we build them up? How do we build them up at the pace, the rate? That's the next thing I would point out about your picture. It's all about rate.
Yep.
You want to manage this, it's about rate, right? It's about how things change over time.
The virus can expand a lot faster than we can adapt, is
right.
what we seem to be discovering.
And well, actually, we have. I would say it slightly differently. We have one of the most amazing. If you're a researcher and you want to be crazy at this stage, I don't know if you want to put this up, right? We have one of the most unbelievable natural experiments going on, and there's many of these comparisons. And some of these allow you to, none are pristine experiments, right? But when we take the aggressive, early, highly anticipatory, on the front end of the growth of the rate, actions by Singapore and Hong Kong, if you take the aggressive testing that South Korea is doing, so even though they've had a fairly large outbreak, it has, the last number I saw was 90% can be traced back to this one religious group. Mm-hmm. So you have a relatively pointed major source from which the majority of the transmissions have grown. Their aggressive testing has been able to get what could easily have gotten way out of hand under control, even though still the number of cases and the number of fatalities are significant in their own right. Now we can compare those with Italy, which was slow. The United States, which is still unfolding as to how big it's going to be, but all accounts are that it is very slow in responding.
To respond, yeah.
And capturing this early anticipatory so you can keep up with the rate and slow down the rate and keep it in a manageable. Now, interestingly, this gets into things for where people should be concerned and not concerned, right? Because that's part of the public communication and risk perception. So risk does come back in for the public, which is think of a young person off at college and their parents being concerned. Well, the risk to that young person is low as far as we know from this illness, right? Unless they have some other things going on. It's not zero, right? But it's very low. So parents are concerned, but what's the issue is, well, if you move around, you come home, right? Or you've been off on spring break and you go back to school and then you come home. As you move around, you become a vector for transmission. Mm-hmm. As you become a vector for transmission, how does that directly or through multi-hops get to vulnerable populations? Yep. Is it your grandfather or grandmother who is nearby? That becomes at risk. And this is where our colleagues have talked about this disease hitting, in particular, being a kind of sweet spot in its characteristics, in that it is it's fairly highly transmittable compared to some of the other outbreaks we've had. Significantly by the statistics that the infectious disease people use, specialists use, and you can look up those exact numbers, but it's significantly more transmittable. We have some airborne close contact aspects of this. It is a period where people don't know they're sick. So they can transmit when they wouldn't go to the hospital, where in some of the more severe illnesses that quickly come on, people quickly go to get medical care so they can be identified quickly. So testing and outreach testing becomes more and more critical in this case. We have a lethality that is high enough, but low enough, right? If it was higher, it would tend to burn out faster. Mm-hmm. But it's high enough compared to normal seasonal diseases that it is a novel risk without any natural immunity variations throughout the population. And then you also have increased lethality for segments of the population. Mm-hmm. So some groups are not going to get very sick, or it's just going to be run-of-the-mill and not very discriminable from other seasonal illnesses.
But they could still transmit, even be asymptomatic and transmit.
That's right. So we've got this very interesting combination that maximizes the potential for growth. And again, we're at that perfect place for the question. This is a long-winded answer to your question, but it's good discussion. It's easy to, in English, to say, oh, that's risk. No, it's not risk, it's control. It's about rate. Right? It's, the ability to manage this is to manage the rate at which this thing spreads. Right? If you manage the rate, you manage how much it hits vulnerable populations, you manage the numbers, the rate of numbers that hit the medical system, needing hospitalization or needing ICU care and needing respirators. And so you move through that. So on the one hand, we've got this growth in need. And how do we change that curve on need? What medical care is needed, and then how do we mobilize and generate additional care? Now, we're back on the natural experiment. We've got the U.S. not doing aggressive testing, outreach and testing, so we now fall back on social distancing, canceling large get-togethers, and so. We'll see how, in the long run, what plays out in terms of how that affects the transmission of the disease. We have a breakdown in coordination at the upper echelons of our society in this country, which means we don't have clear ways in Ostrom's polycentric governance by which these upper echelons are supplying resources, mobilizing expertise to say what are the best ways to use the resources available in order to minimize the growth of demand on the healthcare system, as well as to grow the responsiveness of the healthcare system. People will build models. They will draw analogies. They will connect to things to make sense of stuff. And I certainly hear a lot of this just in the people who talk to me as this unfolds locally. There's that sense of unease, and this isn't anything like we've had before. And how do I make sense of it? Yeah. And they will build some kind of model. They will import or benchmark off something. And so if we don't give them good benchmarks, if we don't give them meaningful, solid starting points, they will fill the gap with very diverse and very erroneous models that generate behavior that will be counterproductive in terms of increasing threat and not supporting or not being effective behaviors and not synergizing behaviors that help diffuse the threat of the virus as it spreads.
Dr. Woods, that's an excellent point. People need to make sense of it. They are going to make sense of it in their own ways if we don't provide them better ways to do it.
That's right. And so, they'll do it. They're going to remember part of that cognitive vacuum is they will make sense. They won't import what we think makes sense. They will make sense in their own terms. But we can give them help and anchors and things. Otherwise, you will get these diverse and counterproductive kinds of models and behaviors as a result. How do you help people see when you're outside of the normal range? Whether this was the Columbia accident, and we can go through many others, they were actually getting strong signals. They were outside the envelope of their experience, how things had developed, how things have become well organized, how they operate well, how we understand how they operate, and sometimes don't operate so well. And the answer is, we're not in any of those. We're someplace else. We are outside the envelope. And that requires a whole different set of behaviors. And that wasn't and hasn't been communicated adequately, at least in some cases and in some places.
There are three topics that I want to ask you about in the future. What are the misconceptions that, if we could let them go or if we could correct them, would improve the way we think about it? The second one is other influenza, other viral outbreaks have been characterized by an even more deadly second wave. Suppose that we get this first wave under control. What are the things that we can do that would prepare us to mitigate the second wave, which doesn't have to be inevitable, but has happened in the past? Then the third is, how would we apply some of the resilience engineering frameworks, the way we thinking, the theories of resilience engineering, how would we apply it in this case?